Hi everyone, welcome back to Neurospicy Nursing. So this video is just going a little bit more in depth into the antibiotics 'cause I felt like I didn't do enough in that last one and didn't really kind of do them justice on like the topics that you needed to know. So this is kind of a part two. This is the anti-infectives lecture. Just more kind of on the antibiotics um, and all of the different classes of antibiotics. Okay, so just a quick refresher. There's a bactericidal and bacteriostatic. Um, I talked a little bit about that in the last lecture, but those are our two. Okay, and then so here are some key reasons why we're going to use antibiotics, like or for super infections, at least some of the most common super infections like C. diff and MRSA. Again, MRSA, that's that penicillins resistant staph infection. Um, C. diff, um, you know, it's C. diff. I can't pronounce it, but C. diff. Um, and then again, it's from broad spectrum antibiotics, or like carbapenems. They can carry a higher risk of people developing super infections. And our high risk individuals are really going to be our neutropenic patients, or patients with compromised immune systems. So they're already susceptible to these super infections, like individuals who have HIV, or if they take immunosuppressing drugs like the TNFs and TNF antagonists and the DMARDs. So one of the best things to do to kind of help, at least for in the C. diff case, is making sure that if you are on antibiotics that you're taking probiotics, because it's going to help put back that good bacteria. Hand hygiene is another really important one. Making sure that you're using soap and water. Alcohol-based sanitizers are great. However, they don't kill off everything, right? There are certain pathogens that the alcohol-based sanitizer is not going to help with. So you have to make sure that you are also using soap and water, particularly when you're eating, and you know if preferable, if you know that you're going to be dealing with a patient who is immunocompromised, washing your hands being the first thing that you're going in there doing, I think that's also very important. And then again, make sure that you educate your patients. Antibiotics are not for viruses. Antibiotics are for bacterial infections. So if someone comes in with RSV, that's a virus. Antibiotics are not going to be a treatment option for those individuals. Also, make sure we're completing the full course of antibiotics. That's also going to help in preventing antibiotic resistance amongst pathogens. So, back to kind of like the mycins, right? We have all these different types of mycins. We have the aminoglycosides, the macrolides, and the vancomycins. Again, some of them are bactericidal, some of them are bacteriostatic. Vanc is that one where you're going to have to make sure that you're monitoring for that flushing syndrome. So aminoglycosides, they are, you do have to worry about it being harmful to fetuses. Um, Also, it can cause confusion, seizures, numbness, and tingling. So I talked a little bit about that peripheral neuropathy type symptom that individuals can get. So again, vitamin B6 is going to be very, very important for helping with some of those symptoms. However, new acute onset confusion, that is a red flag. We're probably going to stop this medication. Do make sure that you note that aminoglycosides are more going to be focused on gram-negative bacteria rather than gram-positive bacteria. So what they do is, since it's bactericidal, obviously they're going to kill off the bacteria, but they're hopefully just going to, it works on that protein synthesis pathway. So that's how they help kill off the bacteria. Um, Also, these are autotoxic medications. So things like vertigo, when we're thinking about our cranial nerves, right? That's that nerve, that vestibular cochlear nerve is going to be affected. So things that you see when that nerve is affected are also things that you're going to see with ototoxicity, like vertigo, hearing loss. Again, remember there are two different types of hearing loss. Um, Sometimes, if we don't stop these medications, it can lead to permanent damage. So if they are having, neurotoxic, ototoxic, or nephrotoxic symptoms, we do have to stop this medication and they need to go see specialists in those areas, like maybe a neurologist or a ENT or a nephrologist, just to make sure that no permanent damage was done by taking this medication. And then again, nephrotoxic kidney damage that increased in the BUN creatinine. And then when we see the increase in those numbers, we are going to see a decrease in the eGFR. That's at that filtration rate. Um, and it is also kind of in relation to how well your kidneys are perfusing too. Just some indications on why we may use aminoglycosides. SIBO infections, small intestinal bacterial overgrowth. So this is that normal gut bacteria that for some reason decided to just get overwhelming in the GI tract. And then for some GI surgeries, we also can use aminoglycosides to like kind of prophylactically going into a GI surgery. Because remember, with GI surgeries, there is that risk of peritonitis, so that infection of the peritoneal cavity. So that's another thing to keep in mind. And then again, just make sure like hearing changes absolutely are going to be a stop signal. But these are really the big three things that you're going to need to know with the aminoglycosides. Okay, so the macrolides, heart, gut, and liver are pretty important for these ones. They are commonly used for H influenza. If you don't know what H influenza is, we actually do have a vaccine for this virus. It's commonly given to individuals when they are younger. Um, and it is also a cause of getting croup. So that is another thing. And it sounds like, you think influenza, you think the flu. But this is actually a bacteria. Um, and again, you do get the vaccine when you are younger for uh, helping kind of prevent, you know, um, this type of infection. This vaccine, if you've ever heard of it, it's going to it abbreviated. It's the HIB, so lowercase I, lowercase b, and that is covering this specific bacteria. Um, it's usually, I know for sure if they're less than 5, they can get this. Some older children and adults don't really need this vaccine unless, again, immunocompromisation. They might need another vaccine. But it's a conjugate, so technically that means that it's the bacteria and then it has almost like a sweet sugary coating on top of it. But um, Other than that, yeah, that's pretty much everything I feel like you guys might need to know about H influenza. Again, do know that it is a vaccine. The first dose is at 2 months. Um, and then there's doses at 4 and 6 months. And then there's usually a booster at like 15-ish months, but by at least 5 years, because some people may have to have the series come spread out, or they need more than one dose. By 5 years of age, everyone, not everyone, because some people decline vaccines, but most individuals will be vaccinated against this bacteria. But again, that doesn't mean that you can't get it. Vaccines, they just help you lessen the amount of or severity of viruses. Um, and then again, with croup, it's it's related to bacterial croup. There's different types of croup. Um, or if you've ever heard of parainfluenza, that's another thing that individuals can get kind of it's basically the same thing, influenza and bacterial croup, which is the epiglottitis, so the inflammation of the epiglottis in children, and it causes that stridor sound that we all hate. Um, so that's what this is given for. I'm going to go more into stridor and a little bit about bacterial croup, epiglottitis in the respiratory lecture, but I really wanted to make sure that you guys know that that is a treatment for this. Children will be getting it, um, even though it is technically maybe not something that we should be giving to some pregnant women. It is at least um, I'm trying to really like think of the best way to kind of explain what I'm saying, but yeah, pregnant women maybe not, but children above a certain age, um, this would be fine. Also, make sure that you guys keep in mind that for some of the teratogenic medications, yes, they are teratogenic if they're in like the first or second trimester, but in the third trimester, for certain things, it may be okay to give them that medication just because we know at that point there's no really risk for any birth defects, like at least later in their pregnancy, right? You don't want to give it kind of in that first trimester just because there's so much unfortunately room for harm, um, that they're not safe. But uh, another, you know, thing that we can use this for besides C. diff is actually going to be some types of chlamydia. Um, so that's another thing to note. Um, we actually give the erythromycin drops during the birthing process, right after baby's delivered. They go and they put like these really kind of gross looking eye drops into the baby's eyes. And that is this. And it is to help prevent, if mom did have some sort of STI or STD, it doesn't spread to baby and cause blindness. So that's another reason why. Some women do choose, even if they do have um, chlamydia, to still have a vaginal delivery. And sometimes providers have to be like, okay, well, if you're not going to sign the consent, at least be aware of the risks of you doing so. And, even with that, and they're aware of the risks, they still could do it. Sometimes ethics, you know, um, is not always there. Um, but, just be that as it may, that's another reason why we use macrolids. Again, I talked about how it has that prolonged QT interval. Um, I'm going to go into this way more in depth and show you kind of what that PQRST complex is, kind of get you guys knowing what that is and kind of what I mean when I say prolonged QT interval. I have an actual photo of that here, so hopefully that helps. And then another reason why is because since this medication, you know, is can be given intravenously, there is obviously we're bypassing that first pass effect by the liver when we talked about that first lecture for metabolism. So that's another reason why we have to make sure that we are monitoring these individuals. So it's hard on the liver. It's going to be another medication where we are going to tell them up to 3 days after treatment, really try not to drink anything. And then the allergic reaction, any angioedema, swelling of face, throat, eyes. Okay, so vancomycin. So Um, I mentioned before, it's got a very, very narrow therapeutic window, right? So anything below 5 is going to be ineffective, and anything above 15 is going to be toxic. So we have to make sure that we are keeping that trough level in the proper um, area, and then our peak levels, the peak of the medication's effectiveness should be between 20 and 40 micrograms. So this medication, vancomycin, think of it, it sounds kind of silly as a comparison, but fentanyl is also in micrograms. Off the top of my head, it's really only two medications that I could think of that I've seen that are obviously there are more, but ones that I have had experience with um, that are in micrograms. So that may help you, that may not, I'm not sure, but this is in micrograms, not milligrams. So that's another thing to keep in mind. And again, we have to make sure that with every single dose of this medication that we're drawing blood to make sure that we're monitoring those peak and trough levels. All right, so I talked about the red man syndrome. It's because of the rapid infusion of the vancomycin. Again, make sure that you stop the infusion immediately. First priority thing that you're going to do, stop the infusion, and then you're going to notify the provider second. Um, I say second because, technically you're stopping it and you're notifying them at the same time, but it's probably going to take a minute for you to give S-bar. In that process of you giving S-bar, you should be stopping that medication. The provider, maybe while you're on the phone with them, if they trust your judgment and you're describing the symptoms that this patient has, they can either tell you, okay, we're going to stop it and maybe reevaluate, or they'll be like, okay, just restart the medication, but at a way slower rate. Um, and then again, it is very, very intense on the vascular system. So it's very harsh on the vascular system. So it's very, very common for this medication to, you know, leak out, cause like thrombophlebitis or extroversion. So you have to make sure that you're monitoring that infusion site if it's especially if it's peripheral. Just do that little like squish test. If it feels squishy, if it doesn't feel hard, should be fine. But just another thing to keep in mind. Okay, so tetracyclines, I talked a little bit about the fact that they um, you know, can increase that risk for like sun damage and stuff like that. This is another one that's going to be teratogenic. Um, It's again like teratogenic, mostly kind of in that first, second-ish trimester. It's definitely possible to give doxycycline or any tetracycline in a third trimester. Again, this is more, you're weighing that like benefits to risk ratio. It's not really like Accutane or something like that, where like if you take Accutane while you're pregnant, it can lead to hydrocephalus. It's less like that. Like there are some minorish birth defects and then the teeth staining. But again, for the sake of your test, because things are different in practice, it's going to be teratogenic. So we can actually use these medications to treat endocarditis. I don't know if you guys remember when I was talking in the last lecture for endocarditis, infective endocarditis. Um, we have to make sure that before like dental procedures and certain procedures that these individuals who've had this in their past do get a prophylactic antibiotic. But this can actually also be used to treat the infection of endocarditis itself. Also, Rocky Mountain spotted fever can be treated with this. That's when you get bit by a specific type of tick. And then H. pylori, so one of the leading causes of peptic ulcer disease, we can also use tetracyclines to treat that. Again, it causes photosensitivity. Our patients have to make sure that they're wearing sunscreen and wearing protective clothing. Also wearing actual UV protective glasses or sunglasses, because not all of the glass, just because they have a dark lens on a sunglass does not mean that it's actually UV protective. And then we have the esophageal irritation. So again, pill-induced esophagitis, you have to make sure that these patients are not taking it right before bed. They have to wait at least 30 minutes before laying down and taking this with the full glass of water to kind of reduce that. So another thing to think about is if your patient maybe can't sit up for 30 minutes, they have some sort of musculoskeletal condition where that is very hard for them, or they have some sort of, I'm trying to think of what else, but I know like they can't sit up straight for 30 minutes and, maybe have difficulty um, like swallowing water or um, swallowing water, sitting up, keeping it down, those sort of things, if that makes sense. Guess what I'm trying to say. Um, because of that risk of the esophageal irritation, this might not be the best medication for someone along those lines. Unless, if it's intravenously, it's a little bit different, but maybe the oral pill is not really great. Teeth staining is another thing, causes permanent discoloration in children. Again, that's really why we try not to give it to a pregnant mom. And then there is an interaction with contraception, so they have to make sure that they're using alternate forms of birth control. But again, full glass of water, sitting up for 30 minutes, making sure that they're monitoring their teeth. Oral hygiene is very important. Um, Doxycycline, even though you could brush your teeth 2 times a day, it still may stain your teeth. But making sure that you're educating your patients like, hey, this is what happened, and it's gonna be like this, basically. Um, are just things to let them know, especially if they're younger and they're getting doxycycline, their teeth, because chances are they may not have all of their teeth. Theirs will actually be permanently stained. So the fluoroquinolones, I obviously talked about it. UTIs, STIs, osteomyelitis, they're all ones that we can use. Ciprofloxacin is a super common one, but again, it has that risk for the Achilles tendon rupture. Again, it leads to something called drop foot. So it's like when you ask your patients to press down on your hand like a gas pedal. That's that shortening of that Achilles tendon. So it will stay like that, and then that excessive strain is going to cause that tendon to rupture. So we have to make sure that we are telling our patients, if you have any tightness or pain in your heel, the Achilles tendon area, or that lower calf, make sure that you notify your provider. Another thing is that it can increase uric acid in the blood, which can lead to kidney stones. So they have to make sure that they're increasing their fluid intake. Remember, a normal fluid intake for an adult who doesn't have any regulations on how much fluid they should be drinking is about 2.5 to 3 liters a day. And then again, for urine, it's 30 ml per hour is how much they should be peeing. These individuals also have to make sure that they're wearing sunscreen. And this is another one of those medications that are teratogenic, especially in the first 15 weeks of the pregnancy. And you should be using additional contraceptive if you're on this medication, because it's just the oral pill is not going to cover. So, sulfa drugs. So again, cross-sensitivity alert with glyburide, thiazide diuretics, so that's your hydrochlorothiazide, that calcium-sparing diuretic, furosemide, everything sparing, or everything um, pushed out diuretic, um, are all things that if you are allergic to a sulfa drug, you can also be allergic to those medications. Um, so it's bacteriostatic, so Bactrim, very common, like you've heard Bactrim. SJS, so you get those flu-like symptoms and then that painful blistering rash, and your skin kind of peels off. I hope you guys never see it. But that's what Stevens-Johnson syndrome is. Um, it's more common, like SJS is a little bit more common in like POCs. Not sure why. Don't really know the mechanism of action for that, but yes. I do implore you guys though. I know it sounds a little bit unprofessional to be like referring you guys to a TikTok, but there is a woman who talks about her experience with having a UTI, getting antibiotics, getting SJS, and then I think she took another antibiotic and she got it again. Um, Insane story, but it's real things. They happen to real people. So making sure that you're aware and you educate yourself on those things, it's very important. So Photosensitivity, make sure you're wearing sunscreen, protective clothing, eyewear. It is going to inhibit folic acid, so you have to make sure that you're increasing folic acid when you're taking this medication because it's very important for our red blood cell production. Um, and then dehydration, um, you have an increased risk. So they have to make sure they're drinking a proper amount of fluids. All right. So penicillins and our cephalosporins. So they are going to inhibit bacterial wall synthesis. There is technically a cross sensitivity. It used to be that it was about 10% of the risk of people who have an allergy to penicillins also have an allergy to cephalosporins. Current research now is saying that that is only about 1 to 2%, and then even less for the newer generation cephalosporins. Um, but regardless, it's still going to be very important to make sure that you get the allergy history of an individual. Um, but make sure that you also determine whether or not it was an actual allergy. Diarrhea to a penicillin is not an allergy. That's normal. So making sure that you get like the actual full history of what happened to them. Um, okay. The other thing, penicillin G, I talked about how it's the only um, safe option for treating syphilis in pregnant individuals. I just want to reiterate that again, if we do have a positive syphilis, they are pregnant, even if they are allergic to um, that and have an actual documented penicillin allergy, we're still going to give it to them because it's more of that risk versus reward, right? We would rather try to get the syphilis cleared up. Um, and we can deal with the anaphylactic type reaction. But again, for cephalosporins, at this point, it's kind of a myth. But um, you know, for syphilis, at least, it's non-negotiable. They have to be receiving penicillin G. Um, Getting no treatment at all is rather irresponsible. So yeah, that's all I'm gonna mention on that part. But make sure that, if you do get the detailed history and the provider just sees the allergy to penicillin on the chart and they do a penicillin or a cephalosporin, that you make sure you clarify what that allergy is, or they won't do a cephalosporin. Clarify that allergy with the provider and be like, hey, this was the reaction that they had to penicillin. Um, you know, maybe they can get a cephalosporin. Um, but again, it's all up to providers at the end of the day. Um, and they're the ones who make the final decision. Um, so this is some ripe stuff. I also wanted to mention, I can't remember if I did a very good job about that in the last video, that again, this optic neuritis, it is um, one of the ways your body kind of can affect your eyes, right? Optic neuritis is one of the things that you get when your immune system recognizes your eyes. But that does not mean necessarily that this is what's happening in this case. This could also just be an inflammatory process from it is an inflammatory process from the medication itself. It's not like the joke I made. It's recognizing your immune system is recognizing it, it's going to kill it off. I didn't necessarily mean it like that. More of a little funny haha, but I just wanted to clear that up to make sure that you guys do know that this is an actual side effect of this medication. It does not mean that they now have autoimmunity in their eyes. And then just I wanted to put some, you know, this big wider lens. Antivirals, I didn't really fully go over them in the other lecture, which is why I also wanted to cover them. I just briefly talked about it. So herpes simplex virus, There's herpes 1 and 2. Um, Herpes, if you do have herpes, active herpes lesions during pregnancy and you decide to have a vaginal delivery, that is something that can be transferred to baby, and baby can actually get meningitis. Um, so acyclovir, there are other, the NVIR, those are going to be our antivirals. But herpes simplex is not the same thing as herpes zoster. I know they both have the word herpes in it, but herpes zoster is actually um, more closely related to chickenpox. So when you have chickenpox as a child, you're at higher risk for shingles. This is why you have to make sure you're getting the shingles vaccine to hopefully help prevent that. And then we have cytomegalovirus. It is a very, very intensive virus that you can get in your eyes. Again, I talked a little bit about how individuals with HIV, they do get this. Um, you guys don't need to know like the pathophys for this right now. Maybe next semester, but that's another one. And then the flu is also a virus, as well as COVID-19 is also a virus. So they can take antivirals. I don't think we ever really like, unless it's like a super duper bad case of the flu and COVID now, we don't really give antivirals like that. Um, but don't forget, viruses, they remain in your body for life now that they're in there. Um, I talked about Epstein-Barr virus. It's another one, remains in your body, stays there for life, and then you can get another virus, like if you, I don't know, had chickenpox when you were younger and then you get COVID, you can end up with the shingles because it reactivated that virus. Um, Antifungals, again, the overgrowth of the fungi and the yeast. Yeast is normal on our body. Everybody has yeast on their body. It's normal. Um, but again, this is specifically for the overgrowth, like in the mouth when we see oral thrush. Um, there is technically um, another type of, I'm trying to think of the best way to explain. Um, there is another type of, thrush, if you will, um, that you can get that's not just your mouth. Um, Yeast infections, you can get it in your genital area. Think about the environment. It's, you know, damp, warm, and dark. Um, so feet, diabetic patients have to make sure that we're looking at their feet. They get a lot of fungusy toenails, but other areas as well. So proper hygiene and stuff like that is important. Fungal meningitis is very, very intense. I hope you guys never have to see it. If someone has fungal pneumonia, it's another reason why we would give this antifungal. And then there's antiprotozoal, so Flagyl for bacterial vaginosis, and for certain types of tonsillitis and C. diff. So overall, things that you need to know for your antibiotics. Finish the full course. We're going to monitor for superinfections. We're going to verify allergies and cross sensitivities. Educate your patient on everything that they need to know for this medication and make sure that you are getting your lab values. And that's all I have for you guys. All right. Thank you. Bye.